no relevant disclosures. I want to get folks to understand the available serum and urinary biomarkers for diagnosis, prognosis. We'll talk about guidelines to kind of make it clear and succinct, hopefully. And I'm going to promote the use of online risk calculators for prostate cancer diagnosis. These are free, and nothing else is. So NCCN this year, biomarkers that improve the specificity detection are not as yet mandated as first-line screening tests in conjunction with PSA. That's why we call them secondary. However, there may be some patients who meet PSA standards for consideration of biopsy, but for whom the patient and a physician wanted further defined risk. So the tests we talk about are going to be especially useful for folks with PSAs between about 3 and 10. The probability of higher grade cancers can be further defined utilizing, let's say, free PSA or PSA density, other serum tests like PHI, 4K, or IsoPSA, and a variety of urine tests like SelectMDx, and MyProstateScore, MIPS. The extent of validation of these tests across diverse populations is variable, and the interaction with MRI, as we just heard, is understudied. So for a man with elevated PSA, after repeating that to confirm the PSA is up, doing a DRE, which again, a lot of people don't do anymore, but that is the recommendation, and urologists still do. And after a workup for benign disease, the suggestions are: number one, perform MRI before biopsy if it is available, and it is in most parts of our country, and this is a strong recommendation. Then consider various biomarker tests that improve biopsy specificity before biopsy in those with this serum PSA of, let's say, 3 to 10 range. These includes essentially the ones I mentioned before. And if a patient is felt to be at higher risk despite a negative biopsy, additional tests are also options. And now we get into kind of, okay, serum, free PSA, PHI 4K, urine, in this case PCA3, which was kind of the OG, and MIPS. And you can talk about some tissue tests. Again, I'm not going to go into the genomic stuff, which is mainly for men who have cancer, but this is a confirmed MDX test, which is tissue-based, and it's where negative biopsy samples are assessed for methylation of cancer-specific genes as an indicator of potentially missed cancer due to a field effect. And then PCA3 is really the original biomarker that was FDA approved for use after a negative biopsy. And PCA3 was it was like a band on a gel in Bill Isaacs' lab at Hopkins in the 1990s. That is still specific, but it's sort of hard to get, and there's not any companies supporting it, and we've sort of moved on as urologists, and it's not being used very commonly. A real nice write-up of secondary biomarkers by Robinson et al. Suggests that contemporary validation data over the last 8 years revealed that available biomarkers provide a specificity about 15 to 50% and a sensitivity about 90 to 95% for what's being called clinically significant prostate cancer, grade groups 2 or higher. Clinically, this means that secondary use of biomarker testing in men with elevated PSA could allow for avoidance of up to 15 to 50% of unnecessary prostate biopsies while preserving detection of 90 to 95% of significant cancers that would be detected under the traditional biopsy-all approach. For patients, a test with a high NPV provides assurance that foregoing additional testing is the appropriate choice, and in patients, individualized predictions are basically preferred. For clinicians, on the other hand, a test with a high sensitivity confirms the use of the test will not result in failing to biopsy an unacceptable number of men with higher grade cancers. So the optimal test selection should depend on these and other factors, including ease of ordering, interpretability of results, and of course, cost and coverage. Just a look at what I would consider the secondary liquid biomarkers that are in clinical use for these indications. There are the blood tests in the sense that they are all PSA-based, looking at PSA and PSA isoforms, and we'll highlight a little bit PHI, 4K, and IsoPSA. And then there are urine-based tests, which are RNA-based or methylation-based, not PSA-based typically. The ones that are post-DRE are PCA3, Select, and the MIPS, at least in its current iteration. And the one that doesn't require a DRE is the ExoDx Epi test. PHI was approved by the FDA for cancer detection in this gray zone of 3 to 4 to 10. And it's this algorithm of pro-PSA, total PSA, and free PSA. And in the original publication by Catalona, and these numbers have changed a bit over time, but basically you get 4 quartiles of risk. If your PHI is 0 to 25, your probability of cancer is on the order of about 11%. on up. And so I kind of look at this and I tell folks that are in the lower quartiles, and ideally with a negative MRI, you probably don't need a biopsy. Your risk is less than 20%, and a negative MRI shoots that down even higher because this is agnostic to MRI results. And folks with higher PHIs I worry about. So this, when I get my confirmatory PSA, I just get a PHI because I get my PSA and I get a little more information. 4K is quite similar. PHI is kind of a 3K, 3 kallikreins, and this one has 4 kallikreins. This one is more expensive. It's never really been checked head-to-head with PHI, but the data suggest very, very similar outcomes. And their readout is a readout for % chance of higher grade prostate cancer, whereas the classic PHI readout is just do you have cancer or not. We're obviously going to a world where we're more interested in the higher grade stuff. And IsoPSA is a newer test. I've not used it myself. It's a structure-focused test that interrogates the PSA isoform composition in the blood, sort of all PSA. Anything PSA product PSA being made, PSA being degraded, et cetera. And they got an AUC of about 0.78 for high-grade prostate cancer detection, sensitivity about 90%, and NPV about 89%. So those numbers were encouraging enough for them to forge ahead and promote this test. So those are the serum ones. And there's a whole urinary biomarker panel, which is near and dear to urologists because that's where we are. We're the ones doing the prostate exams. We're the ones collecting the urine easily. I highlighted in red some of the differences. So PCA3, which we are not using much, although it's the longest standing test in the urine. It was indicated for repeat biopsy. It is FDA approved. It needs a DRE, and it has a reasonable AUC. On the upper right, the MIPS test, which measures PCA3 and T2-ERG, also requires a prostate exam, has a slightly better AUC, and this is being revised now by its original creators, and I think the MIPS 2.0 and et cetera is going to be a whole bunch of a panel of genes, not just PCA3 and T2-ERG. There's the SelectMDx, which is a test for high-grade cancer, measures HOXC6 and DLX1 methylation. It's also a post-DRE exam requirement, and they have the highest performance that I could find with an AUC of 0.9. And then there's the ExoDx Epi test, again for high-grade disease. They measure exosomal PCA3 and ERG, and this is the one test right now where the DRE is not needed, so it's quite easy to get with a home kit or in the office on the way out the door as a secondary biomarker. And again, none of those are really PSA-based, which provides you a different sort of approach. Again, few head-to-head comparisons. As Dr. Marella said, how do we assess their performance? The best thing I think to do is compare them to predictive nomograms that have been validated based on data from thousands of men worldwide. And I think the better secondary biomarker tests stand up and improve on nomogram predictions. I really feel these nomograms should be in greater rotation in urology clinics nationwide. In fact, the EAU includes the use of these calculators into both prostate cancer screening and clinical pathways. These free internet-based calculators are all derived from randomized level 1 evidence. And of the many, these 3 have been validated in 10 or more external cohorts. So these are robust. And one is using the ERSPC data, that's the RPC risk calculator. One's using the prostate cancer prevention trial data, and that's the PCPT risk calculator. And the last one we'll talk a little bit about is the newest, and it's the prostate biopsy collaborative group risk calculator. Dr. Vickers and colleagues came up with sort of a more modern take on these old data sets. Their caveats were that the PCPT and ERSPC data all were from randomized trials in the 6 core biopsy era, and the vast majority of men in their data sets had low PSAs. These are not the people that we're basically seeing in clinic today to get biopsies, whose PSAs are 3 to 10 and are getting, well sampled, let alone getting MRIs. So this PBCG calculator is based on contemporary data, uses 12 core biopsy era, and a majority of men in the higher PSA ranges. And if you compare the calculators, again, at the right, let's focus on, you got a calibration plot, which shows that the new PBCG one is well calibrated, and that the PCPT, on the other hand, underestimated risk by about 20% across all risk thresholds. So if you see a predicted risk on the x-axis of, say, 40%, you go up, and the PCPT-RC curve is at about 80%, or 60 to 80%. So over that, and basically underestimating risk significantly, whereas the PBCG has that sort of straight line. So this is what it looks like. You just go to the riskcalc.org. I think it's a Cleveland Clinic linked website, and you put in patients' race, age, PSA, DRE, prior biopsy, family history. And if you know more information, there's even a secondary one that asks you, MRI results, et cetera, and you get a nice readout of no cancer, chance of low-grade cancer, and the red figures are the 19% chance of high-grade prostate cancer in this example. And again, I said the biomarkers that are the best are the ones that can go head-to-head with the calculator and improve on it. So there are publications that show that PHI improves on the PCPT and the ERSPC for the detection of what we term aggressive cancer nowadays, GG2 or higher. SelectMDx also did that, and they did a validation study for the detection of more significant prostate cancer. It was extremely high NPVs for very high grade and high grade cancer with an AUC of 0.9, and you can see there they've pushed the ROC curve into a very nice range of 0.90 compared to just the PCPT-RC and let's say urinary PCA3. And EPI has also done that with the ExoDx test. They also have gone head-to-head with the RSPC, and they noticed that the test is better and or additive, and you can get AUCs that are higher and get NPVs that are higher than using of the risk calculators alone. So I think any test that can compete with or be additive to the risk calculators is going to be helpful because they're based on PSA and history alone. So I think the future, at the bottom I say adding imaging findings to these predictive tests and nomograms. We just had that discussion. Obviously, that's going to be critical. Adding genetics, rare pathogenic mutations, and polygenic risk scores to the secondary biomarker arena is going to be important. We know that certain rare pathogenic mutations increase risk of cancer, although their prevalence is quite low. Polygenic risk scores are getting attention. These are SNP arrays done. Everybody in the room has a PRS, unlike not all of us have RPMs. And these have been predictive of cancer presence typically rather than presence of high-grade or lethal cancer. But there are some new iterations of polygenic risk scores with new SNPs that are being put together that have some ability to detect higher-grade cancer now as well, or predict higher-grade cancer. And they're being improved upon. GoPath is one company you can use to get your PRS checked. And then there's comprehensive platforms like Stockholm 3 that look at a variety of PSA and PSI isoforms, genetics background, and clinical data, and they put it all together for you to predict the presence of high-grade cancer. So I think this is where we're headed. Again, in conclusion, I'm a fan of online risk calculators. They take very little time to use. You have that clinical data as a clinician to pop in and give patients a readout of their risk of prostate cancer. PHI, 4K, IsoPSA, and various non-PSA-based urinary tests like EPI, MPS, and particularly SelectMDx seem to offer improved specificity, and they may help identify men with higher grade cancer. But you really want to look for a high NPV and a sensitivity that is high to help biopsy decision making, I believe. And ultimately, genetics and combined tests are starting to enter this arena, integrating the biomarkers, the genetics, the demographic info, and imaging throughout, probably via AI is, I think, the foreseeable future. And thank you for letting me talk about this.